Hello, I'm Anika Viswish. I'm excited to introduce our next speaker, Dr. Kenji Obadiah, at the Africa Science Buskers Festival 2021. Dr. Kenji holds degrees from 3 different countries and continents. He obtained his PhD in infectious diseases from the John A. Burns School of Medicine in America, Masters in Public Health from the Manchester Metropolitan University in England, and BLMS from the University of Buea in Cameroon. Dr. Kenji has worked extensively on profiling the infectious etiologies of febrile illnesses in Cameroon and developed the Ebola virus and Zika virus subunit vaccines. Dr. Kenji currently works at Stanford Medicine in America, where he is in charge of the scientific, technical, and operational aspects of infectious disease testing. His current research focuses on developing and validating novel diagnostic tests. We are extremely thrilled to have you today at the Africa Science Buskers Festival 2021. Thank you for joining us. Please welcome Dr. Kenji.
Thank you so much, Annie, for a warm welcome. I think I'm just going to start by sharing my screen. Let me see how that goes. Is that good enough?
Yes, we can see your screen.
All right, thank you so much. Yeah, thanks for the introduction. It's such a great pleasure for me to be here to talk to you about fevers in the tropics. That's one of my favorite topics because I grew up in Cameroon and I had several episodes of fever. So today I just want to walk you guys, through what could be causing fever in the tropics because most often when you hear fever illnesses, especially in most African countries, it's always attributed to malaria. As Anika rightly said, I work at Stanford Healthcare and at Stanford Medicine. So just to begin, if you look at the picture on the right, this is not a diagnostic challenge, for anybody that is in the medical field. If you look, you see that there is a patient and the patient has a worm that is creeping beneath the eye. It is easy. You can say that, hey, this patient is suffering from onchocerciasis because you can see what is actually going on. As opposed to this other picture, this is one of our study participants. I already have consent to use the picture. When we started the study and I came to that hospital, she was having fever. Now, when a patient presents with fever, it is extremely very, very challenging to know what is causing the fever because there are a lot of other things that can cause febrile illnesses. So this is a difficult diagnosis to make, comparing fever and also comparing something that you have the worm that is creeping beneath the eye. So the history of fever in medicine is very ancient. I don't intend to start from the beginning, but instead I would like to start from this gentleman. Some of you may recognize it. This is David Livingstone. The reason why I want us to start from Livingstone is because he kept details of his own records, and the details that he kept of his records 450 years ago is still relevant for us to understand, fever then and now, and to understand what has changed. Livingstone died in Zambia from fever, of course, and dysentery. So I hope you don't mind me entertaining you with a little bit of history. So at that time, during the colonial period, or almost 150 years ago, fever was referred to as the fever. So they considered fever as a single disease, and in such a way that fever was not known to be caused by germs. According to Livingstone and according to all the records that he made, for you to have fever, you need to come across marshy areas. For example, if you look at this cartoon to my left, this is Livingstone being crossed one of those marshy areas. So they believe that when you came across dirt and all the like, that's how you had fever. And if you don't know the word malaria, I mean, those that are in the tropics will probably be familiar with malaria. It actually comes from the internal word mal, which means bad, and area, which means air. So malaria at that time was seen as bad air. So if you came across a place that had bad air and you have fever, it was considered that you have malaria, and they thought that the malaria was caused by that bad air, in such a way that Livingstone identified some moral factors that can prevent you from having the fever. For example, if you live in places that were clean, it will prevent you from having the fever. If you did exercises, it will also prevent you from having the fever. So this is one of those treatments that were being given to people that had the fever. As you can see, if you look at the cartoon itself, it is swamp. So they thought that they are treating somebody that has gotten fever because that person was exposed to a swampy area. So fever then and now, what has changed? What has changed in terms of our understanding? That marshy area that Livingstone was referring to, which we now call the environment, was a good breeding ground for mosquitoes. They did not identify at that time that mosquitoes were breeding in those marshy areas. One thing that have also changed is that at that time they only had two associations: the environment and the host. But now we understand that the pathogen has to be present. So you need to have those three things for an infection to take place and for fever to occur. Now, we're beginning to appreciate that you have the mosquito that stays in the marshy area. For example, the Anopheles mosquito is going to transmit a certain parasite, which is called Plasmodium falciparum, to the host. And when that parasite is transmitted to the host, it now causes what is referred to as malaria. So our knowledge has changed, that fever, instead of being considered as a single disease, is instead of a symptom of several different diseases. So now we understand that fever is a symptom of several diseases, as compared to in those days where fever was considered as a single disease. So I hope this history gives you a little bit of perspective on fever, what was known at that time and what has changed now. So Western medicine at that time was mostly focused on the colonial masters, and it was mostly focused on tropical medicine. During the scramble for Africa, most of them had malaria, which was referred to as the fever. But then in 2006, the World Health Organization adopted a certain guideline to, like, any person that presents with fever in the hospital should be treated for malaria. So this now led to the notion that all fevers are caused by malaria. Now the problem is that if you attribute all fevers to malaria, you'll be missing other causes of febrile illnesses, which is not malaria, and you'll be treating other causes of fever other causes of febrile illnesses as malaria. Meanwhile, it's not malaria, and that patient can die from, for example, pneumonia, because anti-malaria is not going to treat pneumonia. So this is just a slide that I thought I should put it there, where you have people that were positive for malaria as compared to those that were negative for malaria, how many of them died. As you can see, those that were positive for malaria, about 7% of them died. They were all treated for malaria, but 7% still died. Those that were negative for malaria, you see that they had a higher mortality, because these people were negative for malaria, but they were being treated for something else. For example, maybe that person had pneumonia and you are treating for malaria, and the person would die from pneumonia and the right cause of that malaria. So that brings us, to what my research has been focused on in the tropics. Like, what is the malaria situation? Are all fevers caused by malaria? That is the basic question that I would like us to answer today. The first thing that we did is we went to Cameroon, that's in West Africa. We recruited about 551 study participants. So these are people that came to various clinics and hospitals that presented with fever. First of all, we wanted to understand the malaria situation in the country. So we collected blood from all those study participants. We tested them for malaria using 3 different methods, because we really wanted to be sure that you have malaria. And the most sensitive method is what is referred to as PCR. That's what we also use in testing for malaria. But most importantly, we wanted to see what is it that the doctors do. So at the end of the hospital visit for each of those patients, we take the hospital book of that patient to actually investigate if the doctor diagnosed malaria clinically, if the doctors adhered to the results that was given to them by the laboratory technician. For example, if the laboratory technician says that this is positive for malaria, did the doctor treat for malaria? And if the laboratory technician gives the result as negative for malaria, did the doctor still treat for malaria? So at the tail end, what did we find out? We found out that malaria is still a big problem. especially in Cameroon. About 54% of the participants were positive for malaria by the most sensitive method that we use. But most importantly, what we realize is that 92% of those study participants were diagnosed as having malaria clinically, meaning that they were treated for malaria. So even though only 54% of them actually had malaria. So this means that 38% of the participants that were clinically diagnosed as having malaria had fever that was caused by other pathogens, and they did not receive treatment for the other pathogens. So that's the summary of what this table here is trying to show us. Then the next question is, what else is causing fever in this group of study participants that are negative for malaria? Because if they are negative for malaria and they are having fever, it means that something is causing that fever. And one of the limitations, in low and medium income countries is that we already lack the diagnostic tools to be able to test for all these different pathogens. So what we did was that we brought in all these diagnostic tools to our study sites. Some of them were just rapid diagnostic tests that you could just use 10 minutes and you know the result. And we ran a panel of about 25 different pathogens that could cause fever. It's not only malaria that could cause fever. So in this group of patients that were negative for malaria, we're trying to investigate what else is causing fever in this group of patients. But also mind you that somebody that has malaria can also be co-infected with another pathogen. So we tested everybody regardless of your malaria status. So when you came to the hospital, we collected blood samples. We also collected stool samples from the patient. Then we tested them for a bunch of pathogens, including pathogens that can cause upper respiratory tract infections, pathogens that can cause infection in your stomach and all the like. So what did we find out? This is just a summary of the different etiologies of febrile illnesses. As you can see, malaria was still the #1 cause of fever in these patients that presented with fever in the hospitals. But most importantly, you can also see that we identified a lot of other pathogens that was causing fever in these patients, from toxoplasma to entamoeba, to flu and all like. So it was not only malaria that was causing fever, there were also other pathogens that were causing fever in this group of patients. Then we now decided to stratify our data based on age group. As you know, malaria is a huge problem in children less than 5 years old. So we wanted to see what is the malaria situation in this group of children, and also compared to the other pathogens that were causing fever. So if you look at children that were 0 to 5 years old, of course, malaria had a high prevalence, but what was causing a lot of febrile illnesses in this group of children was upper respiratory tract infections. This is extremely very important because most of these children that presented with upper respiratory tract infections were treated for malaria. Now, when you have an upper respiratory tract infection and you are being treated for malaria, that anti-malaria treatment doesn't treat the upper respiratory tract infection. Most often, some of these kids will require antibiotics, to be able to treat bacterial pneumonia and all the like. So we stratify the data in terms of age group. So we have 0 to 5, 6 to 10, 11 to 16, and greater than 17 years old. As you can see, depending on the population in which you find yourself, there was some kind of heterogeneous distribution in the different pathogens that cause febrile illnesses. Now, since respiratory pathogens, were the highest that we identified, we now decided to go deep into those different respiratory pathogens to see which are those respiratory pathogens that could be incriminating for causing fever. And as expected, respiratory syncytial virus was the #1 cause of febrile illnesses in this group of people. So without even going through all this scientific jargon and everything, what this table shows us is that apart from malaria, there are other causes of febrile illnesses in children, especially in the tropics. So they shouldn't only be treated for malaria, they should be investigated for other causes of fever, especially if the malaria test is negative. But then moving forward, if somebody has malaria and is being treated for malaria and is not responding to treatment, what could be happening? Most often, we fail to negate the fact that this person could also be co-infected with another pathogen. So meaning that you could have malaria plus typhoid. And that is a very, very common co-infection in most tropical countries. Somebody has malaria and has typhoid. So if you're only treating for malaria, you will not be treating for typhoid because typhoid needs an antibiotic. So we also investigated co-infection, and as you can see, we stratified the data into two. So you see malaria positive and malaria negative. And we saw a lot of co-infections with other pathogens as well. So what is this telling us? This is telling us that when a patient comes to the hospital, it's very important for us to do a full investigation to be able to identify these causes of febrile illnesses, because some of them could be co-infections and some of them could not be malaria as well. Then, since most of the diagnosis in tropical countries is based on clinical signs and symptoms, we wanted to see which are those clinical signs and symptoms that are most associated with malaria and typhoid, in such a way that in places where they don't have all these diagnostic tools, the doctor could just go based on some of these clinical signs and symptoms, even though it's not so recommended because the specificity is a challenge, because we can have other illnesses, or other pathogens that will present with the same clinical signs and symptoms. And for malaria, we realized that asthenia, headache, and vomiting were most associated with malaria. And for typhoid, vomiting and abdominal pain were most associated with typhoid. So it means that if somebody comes with fever and is having headache and probably having abdominal pain and vomiting, most likely that person is having typhoid. And it could still be that person has typhoid plus malaria as well. So in conclusion, our results shows evidence of non-malarial febrile illnesses in Cameroon that should be considered. Please, excuse me one moment. Call you. Yeah, that should be considered by healthcare workers when making differential diagnosis for febrile illnesses, and that the possibility of malaria co-infection should also be kept in mind by healthcare workers in endemic regions. But this is greatly hampered by lack of diagnostic tools. As I said previously, if you don't have those diagnostic tools, you will not be able to diagnose all these different pathogens that are causing febrile illnesses. So two conclusions from here: there are other things that cause fever in tropical countries apart from malaria, and that there is a possibility that somebody having malaria could also be co-infected with other febrile illnesses. Now, the impact of our study was really great. It has a huge impact in terms of public health. It also has a huge impact in terms of policy, and also it also has a huge impact in medicine. So at the end of this study, we're able to present these results to the Ministry of Public Health in Cameroon, and we're able to have different seminars that we educated medical doctors in Cameroon on the various causes of fever. So at the tail end of the study, we're able to come up with a profile of etiologies that can cause febrile illnesses in Cameroon, meaning that the doctors knew that if not malaria, it could be this, and that. So it had a huge impact. And for the future plans, because diagnostic tests are really limited, one of the things that we are currently working on is to come up with what is called a multiplex diagnostic kit, meaning that you take a little kit, and from that one specific kit, you are able to test for several pathogens. For example, you just put a drop of blood, and you can test for malaria, typhoid, and leptospirosis at the same time. So that's one of the things that we are currently working on, to come up with a combo diagnostic test, so you could test for many pathogens as possible. And I'm also working on a book titled Etiologies of Febrile Illnesses in the Tropics. This is going to be like an educational material for medical doctors, for other healthcare personnel as well. So that's the future plans. And also we are working on what is called the fever app, in such a way that a patient comes with fever, and the doctor can put in all these different clinical signs and symptoms, and it's going to give you the likelihood of that it could be this particular pathogen. This is in areas where diagnostic tools are not available. So these are the three things that we are currently working on, and hopefully we should have some of them released very soon. And I would like to thank a lot of people that that help in this study. I had a lot of collaborators on this work, and also where the funding came from. So thank you so much. I think we still have some time, probably about 7 minutes or so, and I'll be glad to take your questions. Thank you.
Well, thank you,
Thank,
first of all,
thank you,
Dr.
Dr.
Kenji.
Kenji. Okay, moving on to the question and answer segment. My first question to you, Dr. Kenji, is what advice would you give to young scientists who aspire to be where you are in the scientific and medical field?
Well, what I can tell the young scientists is that never give up on your dreams. For you to attain your dreams, you need to work hard as well, and nothing should stop you. I came from a very humble beginning in Africa. I never knew I'd find myself in Stanford. I worked extremely very hard. I got a scholarship to come to the US. So actually, my studies in the US was paid by the National Institute of Health. So it is possible. I never knew anybody. I didn't have any connection. I worked hard for it. I went online and looked for the scholarships and I got it. And I came here. When I came to the US, I was studying Hawaii. Hawaii, of all places, is a very good touristic site. But seriously, if you take me to Hawaii, I can get lost because I was so focused on my academics and I finished my PhD in 4 years. I finished my PhD with a 4.0 GPA. When I finished, companies were the ones looking for me, jobs were looking for me. So hard work is what pays. So I would tell the young scientists, I will encourage you, continue to work hard. There are some sacrifices that you make now and you will reap the benefits later in the future.
Okay, because of time, we have limited time. My last question to you is, what program did you study for your bachelor's degree?
For my bachelor's degree, I studied clinical laboratory sciences. So clinical laboratory sciences is the program that will permit you to work as a clinical laboratory scientist in a hospital laboratory. So that's what I studied. So that's my background. That's why most of my research is focused on developing diagnostic tools because I'm so passionate about the clinical lab. And that's where my background is from all about.
Okay, thank you, Dr. Kenji. That was wonderful. Thank you for sharing such incredible words of wisdom with these young scientists. It was wonderful working with you. This marks the end of our session.
Thank you so much.
Thank you.
Thank you, Dr. Kenji, for giving an amazing presentation.
You're welcome.
Have a great day.
You too. Bye.
Bye.